Hello, everyone. My name is Dr. Siddiqui. I'm in Canada at the University of Alberta. I would like to thank Dr. Nagia and Radva for inviting me for this presentation. I was there last year. It's a really impressive conference, and I had a really good time there, and I learned a lot myself. Today, I'll be talking about CIDP and some of the latest advancement in the management of CIDP. Here are my disclosures for this presentation. None of them is relevant to today's presentation. Today, I'll be discussing some of the advancement in the CIDP, mainly as it regards to diagnosis. We'll be talking about CIDP variants, some of the treatments which are evolving in the last few years. And then I would really like to touch upon neuropathies, which is a relatively new condition, although it's not CIDP, but it's closely related to CIDP. The CIDP is not a very common condition. Incidence varies from 1 to about 9 per 100,000, depending on the area of the world you're looking at. It mainly affects middle-aged population, mainly males. And more importantly, it's frequently misdiagnosed. Misdiagnosis is overdiagnosis, is in the enthusiasm to find a treatable neuropathy, we label various neuropathies as CIDP, and these patients go through extensive workup and then treatments, though they may not have CIDP. And that is a major issue with this condition in the past. The misdiagnosis occurs mainly because we ignore the clinical presentation, and we'll talk about that. And diagnosis based on testing, sometimes just elevated CSF protein or pseudo response to therapy. We give somebody IVIG and they have a response which is not objective, and we call it a CIDP. We also sometimes tend to ignore some of the red flags in the diagnosis, and that has led to frequent overdiagnosis of CIDP. And at least in North America, we're using IVIG tremendously, so much so that there's a shortage of IVIG because it's being given for inappropriate indications. And one of them is, of course, a neuropathy. So in the last few years, the main emphasis in CIDP has been to sort of clean up the diagnosis, make it more specific. And so the first guidelines that came around 2005 were revised in 2010, and just 2 years back, new guidelines were published to make the diagnosis more accurate and to avoid misdiagnosis. It has simplified the diagnosis. We'll go over that in a second. It has also provided more specific criteria. And based on the evidence we have received from clinical trials over the last 20 years, it has also sort of cleared up some of the treatment issues regarding this condition. So people who have trained 20 years back, like myself, would know that the diagnosis of CIDP was quite confusing. There were terms like possible, probable, definite CIDP. Now, what they've done is, over the last few years, got rid of those terms, and with the typical or classical CIDP and possible CIDP are the two main diagnoses in this. And then over the last few years, we also found out that there are classic CIDP variants, which are now well-defined based on our experience and their response to treatment. The new guidelines have also clarified when to use the supportive investigations and criteria to make a diagnosis. And also, they've come up with some recommendations. So here's the diagnosis for CIDP. There is no still gold standard for the diagnosis. It mainly depends on the history and examination. Mainly the history and examination. And then in certain circumstances, you may need supportive lab evidence, and I'll tell you when you need that. So in a classic CIDP, we all know it's a progressive disease, relapsing or remitting, with symmetric is the keyword, proximal distal symptoms, mainly motor weakness, but also sensory symptoms that involve at least 2 limbs. So that's the classical CIDP. The condition progresses over 8 weeks, maybe gradual progression or relapsing and remitting over 8 weeks. And then they have got classical on exam. You have the classical finding of a peripheral neuropathy. So that's the classical CIDP clinically. In those patients, the diagnosis is simple. As compared to that, then there are CIDP variants. And those are now well defined. And we'll talk about those. And they're easy to remember now because each has got its classical presentation. And then the response to treatment is also quite well known now. So when you have a typical or classical CIDP, all you need is to have confirmatory evidence from nerve conduction studies. You need to find demyelinating findings in at least 2 motor nerves, but also the guideline involves the sensory nerve conduction studies. So if 2 motor and 2 sensory nerves are involved with classical demyelinating findings, your diagnosis is done. So in a classical presentation which I just mentioned, progressive symmetric weakness of proximal and distal limbs, if you get nerve conduction studies which are supportive, and you all know, those who do electrodiagnostic studies, what are the features of demyelination, prolongation of distal motor latency, temporal dispersion of the waveforms, conduction blocks, conduction velocity reduction, prolongation or absence of F waves. They're all very well known. So if you find these findings in 2 motor nerves and you got sensory abnormalities suggestive of demyelination in 2 nerves, the diagnosis is there. You don't need to do any other tests for diagnosis. You may want to do some other tests to make sure these are not some other neuropathy, and we'll go over there in a second. So when do you need supportive criteria? What are the supportive criteria? Supportive criteria can be response to therapy, CSF findings, imaging. These are required when the presentation is typical. It's not the classical presentation. And so, for example, if a patient, you're unsure whether it's classic CIDP versus possible, you got finding in 1 motor nerve, demyelinating findings or sensory findings in 1 motor nerve, it will come in the realm of possible CIDP. And then you may use some of these supportive evidence to confirm the diagnosis. Remember that CIDP can be a lifetime condition, so you want to be absolutely certain putting patients on long-term immunosuppressive therapy. So sometimes in circumstances, it's good to use supportive criteria. But in classical presentation with classic nerve studies, you don't need to do all this workup. This is very different from what we started off in early 2000s. At that time, as per the American Academy of Neurology, you had to have abnormal CSF, elevated protein, and nerve biopsy findings to confirm the diagnosis, which is not required anymore. So what about response to therapy? So in patients who got possible CIDP, an objective response to the treatments, IVIG, Plex, or steroids, which is in CIDP, they are highly responsive to one of these 3 treatments. Most patients respond to all these treatments. About anywhere 70 to close to 99% patients respond to these therapies. So if you got an objective, not that the patient is feeling well, if you got objective evidence of improvement in their muscle strength or nerve conduction studies, that gives you the diagnosis. This is a supportive criteria. It is acceptable to make a diagnosis in case you're unsure. Now, if the patient does not improve, then what do we do then? Then you have to look at the reason why they didn't improve, whether your treatment regimen or dosing was adequate, or whether you're missing another diagnosis. And that is where, if a patient is not responsive to these immune therapies, the trial, we'll talk about that, how long do you want to try and what dose. But if a patient is not responding to these 3 treatments, or 1 or 2 or 3 of these treatments, you need to look back and see what is the problem, because CIDP and its variants, most variants respond very well to these treatments. What about CSF? Now, CSF protein is a big, there's a conundrum there. When to use it, when to LP a patient, okay? The CSF protein is elevated in about 50% of patients, maybe 50 to 60% of patients generally, highest being about close to 75%. Now, how much is protein elevated is the question, which is the cutoff that's not very clear. There are no rigorous cutoffs. And the problem is that CSF protein elevation is non-specific. So we do not, the new guidelines do not recommend to use CSF studies in every patient, only in cases where they really doubt. And then what do you do? So it should be considered in patients with possible CIDP as a supportive criteria. If you've got a classic CIDP, you don't need to use this as a supportive criteria. If there are unusual features or systemic symptoms, loss of weight, constitutional symptoms, you may want to use CSF studies. And then if it's an atypical presentation, some CIDP, about 10% of CIDP presents acute CIDP or GBS kind of picture. In that, you can use it as a supportive criteria. Remember that diabetes and elderly folks have got elevated CSF proteins anyway. So we have to interpret this with caution. What about imaging? There are clear guidelines where to use imaging and what modality to use. Now, CIDP, classical CIDP, because of repeated myelation and demyelation, the nerves are enlarged. Because of pathology, there's onion bulb formation. The nerve and nerve root, particularly the proximal nerve segments in the arms and plexus, are increased in size. So you can use this feature as a supportive criteria. Again, in patients with possible CIDP, in classical CIDP, you do not need to use that. Ultrasound is much more commonly being used these days because it's in the hands of neurologists. Now we have got clear cutoff values between different nerve segments. So if you have the ability to get ultrasound of proximal nerves, maybe the brachial plexus or median nerves, and you find abnormalities in two sites, that is highly suggestive of CIDP. Again, it's very easy to do, non-invasive and cheap. As compared to that, MRI is also quite sensitive in that it picks up nerve enlargement or can have change signal in the nerve, or contrast enhancement can be seen mainly in the brachial and lumbar plexus. And if you find that is a strong supportive feature, again, it's because the MRI is the lack of availability everywhere, we don't have much robust data on that. And so we prefer in our center to use ultrasound when we need it. We have ability, we've got a neurologist doing it over here, ultrasound of the nerves. And so we can use that in these patients. This is for adults. In kids, we do not have good standards. So there's no evidence right now to support this in the pediatric population, these imaging studies. Now, what's the role of nerve biopsies? The nerve biopsies are becoming increasingly out of favor these days, and we rarely use it for diagnosing CIDP. In fact, we use it to rule out other causes, okay? Infectious, infiltrative, and other inflammatory causes. For CIDP does not have it's very sensitive or specific, particularly the nerves. Typically, we do sural and peroneal sensory nerves. If we biopsy a nerve which is affected, then it increases the sensitivity. So we typically use it as the last option. I just saw a patient, actually, I'm just coming from clinic. The patient I had long demyelinating neuropathy, and we couldn't find other evidence. So we ended up doing a nerve biopsy, and we found that she had a hereditary neuropathy, demyelinating neuropathy, a rare form, which had onion bulb formation and other features of demyelination on these fibers. So we use it, but very sparingly. Nerve biopsies are now, for CIDP particularly, are not very common, and we use it when we are really stuck. What about immunological testing? Patients, particularly with certain variants, you need them. One of the common mimic of CIDP are neuropathies which are associated with monoclonal gammopathies. So every patient you diagnose with a demyelinating neuropathy, acquired demyelinating neuropathy, these immunologic testing are must, particularly when they got a distal variant. We'll talk about it in a second. So anybody you diagnose with CIDP, you make sure that you do testing for monoclonal gammopathies to make sure these present with demyelinating neuropathies and can resemble CIDP. In patients who have got other conditions you're suspecting, like POEM syndrome, multi-system involvement, you look for VEGF or vascular endothelial growth factor in appropriate patients. Now, in patients with distant CIDP, we'll talk in a second, when the presentation is mainly distant, you need to keep your antennas really high, because these patients may have CIDP mimicker. They may have a demyelinating neuropathy which looks like distal CIDP, but they may have a paraproteinemia. So many times, and the guidelines also recommend that if you don't find them in the first time, you may want to check it again sometime later. And then again, what about the nodal antibodies? We'll talk about that. These antibodies, we check them in almost all patients which present with acute GBS or atypical presentation CIDP, because these are a total different entity. They resemble CIDP sometimes in their clinical presentation, and nerve conduction studies show features of conduction block and whatever. But one of the things common to nodopathies or nodal are that they don't respond to treatment. common IVIG or whatever, their response is poor. And hence, in those patients, we look for these antibodies. So when are you concerned that this may be? So be careful when you make a diagnosis CIDP in these settings. When there is prominent pain, patient reporting pain and paresthesias, they've got autonomic symptoms. They are talking about if you've got diabetes in the patient. And if you have abnormalities of nerve conductions and CSF, but the clinical findings will always have a correlation between clinical and lab findings. Don't make a diagnosis based on lab findings alone. You have to have a classical presentation or science or physical science to support that diagnosis. Don't make the diagnosis on mainly on lab findings. How about acute CIDP? Sometimes patients who present as GBS turn out to be having uh, uh, CIDP. And so about 10%, around 10% of CIDP patients have a presentation like acute GBS. Again, we don't have a really clear-cut indication which patients with GBS will turn out to be CIDP, though acute CIDP patients, what they call them, they, of course, they continue to worsen after 8 weeks. They have repeated relapse and remittances in the 8 weeks. So a relapse in the GBS, particularly multiple relapses, may suggest after getting treatment, maybe that this may be CIDP. So after one infusion of IVIG, you may get improvement, the patient relapses, and then you give another treatment and the patient relapses. That suggests that this may be CIDP. The presentation of acute CIDP versus GBS had certain features, although not clearly distinctive, but they remain ambulatory as compared to GBS, where there's severe weakness. CID patients tend to retain their ambulation. They don't have facial or respiratory muscle weakness. Autonomic involvement in CIDP is not that common. And then they've got more sensory signs than GBS, where they've got fewer sensories. So you find more sensory abnormalities in patients with. But again, there's no hard and fast rule. There's no black and white. Sometimes you cannot definitely tell whether it's a patient with acute CIDP versus GBS. But in these patients who present acute CIDP or nodopathies, need to be ruled out. So send some nodal antibodies, particularly if the patient didn't respond to IVIG. Let's quickly talk about CIDP variants. I think this is the biggest advancement over the last 5 to 10 years, where we now know more about these variants of CIDP. Previously, they used to call atypical CIDP, and there was a lot of hodgepodge and confusing terms. But now there's a clear demarcation. There's the classical CIDP, involvement of proximal and distal muscles, symmetric. Then you got the DADS variant. We'll talk about these, which have got predominantly distal involvement, distal acquired demyelinating, symmetric distal involvement. You got the Lewis-Sumner variant. You got the pure motor variant and the pure sensory variant. The DADS is one I want to really caution you. These patients present with distal acquired demyelinating symmetric pattern involving the hands and feet. They are symmetric. Main issue that they've got significant gait ataxia and gait instability, and because of sensory loss, and also because they've got symmetric weakness in the distal lower limbs. They may have a painful neuropathy. This is one variant you need to think about. But remember that this variant, DADS variant, some of the paraproteinic neuropathies present with this. So be careful about mixing this with CIDP because the treatment is different. So a patient who's presenting with the distal variant of CIDP versus monoclonal gammopathy, if they've got IgM paraproteinemia and they may have anti-MAG antibodies, and you may want to repeat this testing I mentioned before. If the first time is negative, maybe after some time you may repeat this because the treatment for these patients are different. That's a DADS variant. Then we come to the multifocal variant of CIDP, also called MADSAM, multifocal acquired demyelinating sensory and motor neuropathy, Lewis-Sumner syndrome. This is just like CIDP, but it is a multifocal. So you got sensory and motor neuropathy by involving individual nerves. Typically starting with upper limbs, I've seen this quite often. One of the nerves in one limb and another nerve in the other limb will be involved, and then it tends to affect the lower limbs. And this variant does involve the bulbar or cranial nerves. So remember this variant, it's very responsive to IVIG treatment. Sometimes this variant may present with just one nerve involvement, focal CIDP, very rare, but sometimes only one nerve or plexus may be involved. And in these patients, you may require supportive evidence. You may want to image and whatever to make sure this is demyelinating neuropathy like a CIDP. So this is MADSAM. The pure motor variant presents with symmetric proximal and distal motor weakness. This is symmetric as compared to motor neuron disease, which has also motor weakness. This present, remember, this has got symmetric weakness both distally and proximally. Motor weakness, sensations are preserved, and typically the sensory nerve conduction study, you won't find any abnormalities. If they do, they may have subtle abnormalities. The term used is motor predominant CIDP, and this group of patients paradoxically worsen the steroids. So IVIG, the treatment of choice in these patients, again, pure motor, there are few. You can count the differential diagnosis of pure motor weakness on one hand, motor neuron disease, muscle, or HNPP, things like that. And based on clinical presentation and some other features, you can diagnose pure motor weakness with this variant. This is symmetric, proximal, and distal motor weakness. None of the myopathies or motor neuron, HNPP, all those pure motor weakness don't clinically resemble that. And so that's what I wanted to point out over here. Clinical. Look at the clinical presentation of the patient. Nerve conduction studies will show you demyelinating features, of course. And finally, the pure sensory CIDP. This is a rare variant. These patients present purely with sensory abnormality, sensory loss, mainly gait ataxia, and then loss of pinprick and vibratory sensation in the feet. And when you do a testing, you find a sensory neuropathy. No motor involvement, very little motor involvement, and these are rare presentation, and most of these patients end up developing full-blown CIDP down the road. So they're so easy now to remember these 4 or 5 variants of CIDP based on their clinical presentation. And in before we go to treatments of what has happened, so just want to recap what I've just went over. The most advancement in CIDP has taken place in cleaning the diagnosis, clearing up various confusions around various presentations, and then how to differentiate these various CIDP forms with other neuropathies. What about treatments? What are the advancement treatments? Unfortunately, the treatments have not much changed in the last 15 to 20 years, though they are now changing, and I expect that in the next 5 to 10 years, we'll have some very new treatments coming up. The 3 first-line treatments are for the last 20-25 years has been steroids, IVIG, and plasma exchange. All are equally effective in CIDP. The preference depends on not the efficacy, because all effective is based on other factors, side effects, availability, cost. So prednisone or steroids were the mainstay of treatment a long time back, but now in North America, IVIG has taken over naturally because of fewer side effects. But as far as steroids are concerned, people have used different regimens, oral, IV regimens, pulse doses. They've been found to be equally effective. Side effect profile may different. I, in my practice, have continued to use prednisone in cases where with 60 milligrams a day dose and then tapering it. IVIG regimen, again, the standard dose is 2 grams per kilogram, induction dose, and then followed it by maintenance doses. 1 gram per kilogram. The ICE trial, which was done a few years back, showed that this dose, 1 gram per kilogram every 3 weeks, is most commonly used regimen for maintenance dose. Remember that these therapies take time. CIDP patients sometimes they may require 2, 3, up to 5 months of treatment. Before you decide that the patient is not responding to these therapies, you need to give them an adequate trial. For IVIG, that means about 3 to 5 months. I usually monthly doses. I use 1 gram per kilogram every month, 4 weeks for at least 3 treatments to see if the patient responded or not. The guidelines say up to 5 treatments you can before you let go. Plasma exchange again is used sparingly because of its invasive nature, its availability, very effective. But if the first two line of therapies, and sometimes you can use combination, you can steroid and IVIG together. If these don't work, plasma exchange comes in, and we use it in those patients who are not responding. Again, by this stage, we're also looking at other causes, other types or other neuropathies. If the patient has not responded to first line steroid and IVIG, I would start looking elsewhere, and institute plasma exchange, but I'll make sure that I rule out other conditions. Maintenance regimen, I mentioned to you, the way it has been well defined, how to use these therapies. After stability of 6 months, some people use a year, we tend to start reducing the dose or frequency of these treatments. If there's an incomplete, you got a partial response in the first 2-3 months, you may want to increase the dose of frequency or add a second agent. So I've used both steroids and IVIG in combination to get the appropriate response. Again, the regimens are different, I told you, but as long as there's an adequate dose and frequency, you should get a response with the two treatments. And when you're about to reduce the dose, there are ways you can do that, and we'll talk about that in a second. But it's reasonable after a period of stability to start thinking of reducing the dose and frequency of these treatments, maybe by 25% every 3 to 4 months to see if they remain stable, and you keep reducing it over the next 2-3 years to the minimal possible dose. Lately, the SCIG, I don't know how much you're using the subcutaneous immunoglobulin. We using it quite actually. Most of my CIDP patients on maintenance therapy are on now subcutaneous immunoglobulin. I use it 1-to-1 dose, what they were getting prior to the IVIG dose. I just calculate the equal amount of dose and distribute over a week. For example, if somebody is getting 80 grams a month, I'll give them subcutaneous immunoglobulin 20 grams a week based on their tolerance, and just move. And then over time, when they stabilize, I start reducing the dose. Now, the evidence of using other immunosuppressive therapies is limited. These are basically case studies and case series, but I use it quite often, these second line agents, to help reduce the dose of steroids and or IVIG. So I've used azathioprine quite often. Guidelines suggest mycophenolate, cyclosporin, and rituximab can be used to reduce the dose of these other first line therapies. Some of the agents are contraindicated or not indicated because of their side effects and lack of efficacy. Methotrexate and tacrolimus have not found its use in CIDP. But any of these 3 or 4 agents, particularly azathioprine, I've had an excellent experience with that. They're helpful in reducing the dose of other agents. In patients who are not responding at all to any of those treatments, some centers offer the stem cell transplantation. The hematopoietic and VR centers has the ability to do it. I've not used it. I found that combination therapies have been helpful for CIDP patients. Now with nodopathies, there's something that probably will be used in those patients because those are highly resistant patients. But for CIDP, I haven't used stem cell transplantation, though it is indicated in patients who are extremely refractory. What about the CIDP? What are the treatments for those? And I'm just going to quickly mention those. Almost all the variants, which I mentioned, to the DADS variant, distal variant, the MADSAM variant, the pure sensory, pure motor, they're all responsive to first line therapies, IVIG, and their prognosis is pretty similar. Okay? As compared to when we talk about DADS, when you got classic DADS, it should be responsive to first line therapies. If somebody is presenting with distal variant and it's not responsive, you might think of again of DADS, which is MAG, with MAG positive, what we call. This is not classic CIDP. It's not CIDP. It's a proteinemic or paraproteinemic neuropathy, and this is responsive to rituximab. So in patients with DADS variant or anti-MAG antibody, I go to rituximab quickly to see if they got a better response. But again, in MADSAM, again, you use the first-line immunosuppressive therapies, and if you're not getting a response, the multifocal acquired demyelinating sensory and motor neuropathy, you want to try rituximab. They've got they're a little bit more refractory, the BAT-SAM variant. There's other variants I mentioned, pure motor and sensory variant, focal variants. They've got similar efficacy, these first line therapies, and their prognosis is pretty good. Now, a lot about new treatments. Currently, this I just did a search recently about what's going on in the CIDP world. A number of ongoing trials are ongoing in different phases, and we should be getting some results in the next few years. But I just want to point out one therapy which is coming around, and you might have heard about it in myasthenia world. These are the monoclonal antibodies. So all these trials are in various phases, and there's a lot of activity in CIDP, particularly with monoclonal antibodies, rituximab, and some of the other antibodies. The most promising agent are the top two, and our center is part of some of these trials. You're looking at these the FcRn receptor inhibitors. So there are two. Currently in neuromuscular world, there are two monoclonal antibodies, two types. One are the complement inhibitors, which work on the complement at the distal end of the immune pathway and inhibit the complement mediated muscle damage. Those are one class of medications, but upstream are these monoclonal antibodies which block the FcRn receptor, and they're very highly effective. So I'm sure most of you know what FcRn receptor inhibitors are. Basically, the antibodies in our IgG, IgM, IgJ, and IgE, all of them recirculate from the circulation. The way they recirculate is that in the blood vessel wall on the endothelium, they are reabsorbed and then recirculated back into so they are taken up by the endothelial cell, and they are again exocytosed or sent out again in circulation intact. This recirculation is dependent on the FcR portion. The FcR portion of the antibodies is bound to the membrane on FcRn receptor. The FcRn receptor, which is shown here in orange or red, it binds to the antibodies, and when it's taken up in the endosome, it prevents the hydrolysis. So this antibody is not broken down because it's bound to the FcR receptor. Those antibodies which are not bound to the FcR receptor are hydrolyzed and broken down. But those which are bound to the FcR receptors, they are recirculated into circulation. This pathway has been inhibited by a monoclonal antibody. You can inhibit it by binding it to the FcR receptor. And so the antibodies now have no way to bind, and they are taken up intact in the endosome, and most of them are hydrolyzed or broken down, and they're not recirculated. So by blocking the FcRn receptor, they're called FcRn receptor inhibitors, it prevents the recirculation of antibodies. This is just like plasmapheresis, where you filter the antibodies. These are so effective in myasthenia because I deal a lot of patients, and I've got patients on this. They rapidly, within days, the antibody levels go down very fast. And by 70%, the response you get within the first week to 10 days, they are reduced by 60 to 70% reduction in the antibody levels, particularly IgG levels. And so there's a rapid reduction of antibodies, and that helps to modify the immune response, and they've been found to be very effective in myasthenia world. In CIDP, there are currently two trials ongoing, FcRn receptor blockers or FcRn receptor inhibitors. There are two trials ongoing. There are IV medication. There's a subcutaneous form is also coming up, and this is called a plasmapheresis through the skin. Think about it. You reduce the antibody levels dramatically by just giving an injection to the patient, either intravenously or subcutaneously. These trials are ongoing in CIDP. There are two trials right now. More are coming, and I expect that in the next few years you should have some more about the efficacy of these agents. You will hear more about these monoclonal antibodies. But for now, I've already mentioned the current treatments revolve around the first-line agent, particularly the steroid and IVIG, with some steroid-sparing agents are the mainstay. It depends on your comfort level and the area where you practice what is available, but all of them have similar efficacy. In the last few minutes or so, I would like to go over nodopathies. This is a newer concept has developed over the last 5 to 7 years, and the literature is rapidly evolving for nodopathies. What are nodopathies? There are about close to 10 to 15% of patients where uh, they are neuropathies which mimics a CIDP, or sometimes they present acutely like GBS. In those patients, what they found is they've got no antibodies against membrane proteins at the node of Ranvier. You know, the node of Ranvier in these myelinated nerves plays a critical role in the conduction of the electrical signal or impulse. So what we call the oscillatory conduction, the, the, the current jumps from node to node, and that's what gives the speed to the nerve conduction. So thickly myelinated nerves are very fast conducting nerves. It's because of this node of Ranvier. And these antibodies are directed against proteins at the membrane, and they cause the membrane or the terminal myelin loops, these are the myelin loops, to sort of shear away or sort of uh, detach from the axolemma. So here's the axon, here are the terminal loops, and these membrane proteins are attacked by the antibodies, and this lamina gets detached, and so it disrupts the nodal conduction. They found that there's aberrant expression of some of the channels which are involved in conduction, like sodium channels and potassium channels. So over here, there's an electrical blockade of this. So it's not that in other CIDP where the attack is on myelin, the myelin is destroyed. In fact, in these patients, when you do a nerve biopsy, you don't find inflammatory changes over here. You don't find the macrophages against the myelin proteins. And what you find is that the nodal membrane is disrupted or sheared away from the axon, and some of the other channels have been exposed. And that causes electrical changes. There is electrical conduction block or conduction slowing in the nodopathy. So they may present as you may find a conduction block or nerve conduction studies and find demyelinating changes on the nerve conduction studies, but the pathology is very different. It's not like the classic CIDP and GBS where there are macrophages and inflammatory attack on the myelin. It is the antibodies against these membrane proteins which cause the structure of the node to change and hence called the nodopathies. A number of them have been found. These are the most common ones, the four I'm going to mention, but there are new ones are coming. And not only that we know what the nodopathies are, we also know their clinical course now based on cases and case reports. This is a hot topic in demyelinating neuropathies. The nodopathies they are a very strong mimicker. They resemble GBA, they resemble acute CIDP, and so it's very important to diagnose them. And you've got the contactin protein, antibodies against those cause acute or subacute onset of for severe disease with the prompt distal weakness and ataxia. The Casper or contactin associated protein one, the Casper protein, antibodies against that cause again predominantly distal weakness with a painful neuropathy, cranial nerve involvement, respiratory failure. So you can see that they've got additional signs in addition to just motor and sensory symptoms. Neurofashion, there are multiple antibodies they've been detected against this protein. Some are looking at the node, some at the paranode next to the node. And again, there's the neurofashion 155, NF155 attacks mainly the young adults. Again, the disease can have a subacute or chronic course. And then again, a variable distal mode and proximal weakness. Again, ataxia, sensory involvement. And because of that, they may have a tremor. The neurofashion 140, again, this is a nodal protein and presents with a mixed picture, but very rapidly progressive. And I've got a patient very highly resistant to treatment. They become quadriplegic in time, sometimes go into respiratory failure. In these patients, we do try plasmapheresis, which we have found to be effective, but ultimately, I think rituximab is the way to go in these patients. So again, as I mentioned, neuropathies lack inflammation. When you do a nerve biopsy, it's a total different pathogenesis for these conditions, and the response, they are refractory neuropathy. So you give them IVIG, corticosteroids, they don't respond much. Freezes does help in certain cases, and we go to rituximab very quickly. There are certain uh, red flags for the neuropathies I mentioned to you before. If they were rapid course, if they got other symptoms, neuropathic pain, um, autonomic involvement, cranial nerve involvement, think hard about these neuropathies, and also make sure that you send early on look for these antibodies for against these nodal proteins. They're all available. We have got a uh, sort of a lab where we send these very early in the course, particularly in patients who are rapidly progressing. So rituximab is an agent of choice in these patients, though many have got very refractory course, unfortunately. So I think that was my last slide. I'm just going to just conclude by saying that the most advanced in CIDP are regarding diagnosis, the variants. It's much more clear now, and the workup, when to use that. Those have evolved. As I mentioned, the supportive criteria. There are much more clarity regarding that, when to use treatment response, imaging studies, nerve biopsies, CSF, when to use that, which was didn't used to be the case about 10, 15 years back, where there was no consensus, but now there's a consensus building around CIDP and its variants. There's clear guidelines where to use supportive evidence. Treatment wise, I mentioned the mainstay remains steroids, IVIG, and Plex. And then, of course, some of the steroid sparing agents can be used to reduce the dose. We know that um, newer therapies are coming. Monoclonal antibodies, particularly FcRn receptor inhibitors, are on the cusp of breaking in the CIDP world. In the myasthenia gravis world, they've already are there. They're clearly they are showing their efficacy. So we'll see what happens with CIDP. Last point about nodopathies. Make sure that you got your suspicion around that and check for them in those appropriate patients. And finally, rituximab. I use it often if I find a refractory CIDP. So I'll stop here and thank you very much.